The following podcast is part of a certified educational activity titled Changing Times for Hemophilia, Exploring Evidence with Novel and Emerging Nonfactor Therapies. Access the entire activity and complete the post-test at peerview.com/BEN860. Downloadable slides are also available.
Hello, and welcome to Changing Times for Hemophilia, Exploring Evidence with Novel and Emerging Nonfactor Therapies. I'm Dr. Stephen Pipe from the University of Michigan in Ann Arbor, and today we're going to explore some recent developments that can inform the use of nonfactor therapies, particularly as prophylaxis, in the management of patients with hemophilia A or B. We'll also focus on new evidence emerging from the American Society of Hematology annual meeting, but also note important developments that were presented earlier in 2022. And after reviewing this evidence, I'll provide some practical points that will help you apply some of the findings that I'll present. So let's begin. Currently available hemophilia therapies include plasma-derived and recombinant clotting factor concentrates. The recombinant platform has allowed for bioengineered modifications to extend the half-life of factors 8 and 9. In prior decades, those with inhibitors to factor 8 or factor 9 came to rely on bypassing agents, activated prothrombin complex concentrates, or recombinant factor 7A for hemostatic management. However, in recent years, the first non-factor therapy has been available for hemophilia A with and without inhibitors. Emicizumab is a humanized bispecific monoclonal antibody that mimics the hemostatic function of activated factor 8 in coagulation, and it has advantages of subcutaneous administration, a long half-life, and maintenance of stable, steady-state hemostatic levels with prophylaxis. Now, these advancements in hemophilia therapies have enabled more effective management for people with hemophilia, but they don't suit everyone, and several unmet needs still remain. Breakthrough bleeds and joint deterioration is still a challenge for patients, particularly with the severe and moderate severe forms of hemophilia. Our expectations for future treatments is we want to get patients to the point where they have zero bleeds, particularly joint bleeds. The treatment burden of traditional factor prophylaxis has been high, and seeking therapies that have easier and less frequent administration is a priority. We've mentioned already the development of inhibitors. This occurs in up to 30% or more of patients with severe forms of hemophilia A. And ideally, we should have therapies for persons with hemophilia both with and without inhibitors. We want to continue to improve the quality of life for our patients on these therapies, and therapies that will enable persons with hemophilia to live active lives, hopefully similar to non-hemophilic individuals, will go a long way to taking them to those new levels of outcomes. And then access to treatment is also a remaining challenge, and we want to develop therapies that can ultimately be accessible for all persons with hemophilia, including on a global scale. Our topic today are non-factor therapies, and these emerging non-factor therapies share key similarities that may actually improve the management of people with hemophilia and address some of these unmet needs we've just discussed. In general, these therapies are primarily used for prophylaxis, which means there will be required concomitant use of other hemostatic agents if patients have breakthrough bleeding or surgeries. Many of these therapies can be effective in hemophilia A and hemophilia B. So for the first time, we have therapies that are so-called cross-platform. They can also be used in people with and without inhibitors. So this may increase the number of treatment options available for persons with hemophilia A and B with and without inhibitors. A unique aspect of this platform of therapy is that we don't have the peaks and troughs that we've come to be used to with protein replacement therapy like factor 8 and factor 9. And so what we end up with is a more steady state hemostatic correction. One major innovation with these therapies is that they can be delivered subcutaneous, and this is a big shift from the fact that patients previously have had to rely on IV infusions. And in general, they require a reduced frequency of administration compared to factor replacement therapies and the bypassing agents, relieving some of the burden of prophylactic therapy. The rebalancing hemostatic agents are emerging non-factor therapeutics that aim to restore sufficient thrombin generation by targeting the natural anticoagulant pathways. This figure is depicting the impact of factor VIII or factor IX deficiency, resulting in reduced factor Xa generation. However, this effect is amplified through the continued action of the natural anticoagulants, tissue factor pathway inhibitor, which regulates the initiation phase of coagulation, activated protein C, which regulates the amplification phase of coagulation, and then antithrombin, which regulates what's called the common pathway. Now, the combined impact is severely impaired thrombin generation and poor fibrin clot formation, the hallmark of the hemophilias. However, thrombin generation can be restored by targeting the action of these natural anticoagulants, so-called anti-TFPI agents, antithrombin lowering agents, and anti-activated protein C agents. These are the agents approved or in clinical development with their mechanisms of action, the suitable setting for their clinical use, and their phase of development. And we're going to explore recent data involving these agents. We've already mentioned that the first approved non-factor therapy is a first-generation factor VIII mimetic. Now, the hemophilia setting for this therapy is because it's mimicking the action of factor VIII. This is only used for persons with hemophilia A and not for hemophilia B. It is an approved therapy, and it can be used for both inhibitor and non-inhibitor patients. There are two agents that are under development targeting tissue factor pathway inhibitor. And because these are acting on the natural anticoagulant side, these are cross-segments, so they could be used for persons with hemophilia A and B with and without inhibitors. There are second-generation factor VIII mimetics. One called Mim8 has a higher affinity for components of the mechanism of action of this bispecific antibody. And it's intended that this second-generation factor VIII mimetic perhaps would have a higher potency, perhaps allow for reduced intensity of dosing, and maybe even take patients to a higher tier of protection. There's at least one other second-generation factor VIII mimetic on development known as NXT-007, and this has the same overall mechanism of action with a higher affinity. Fitusiran we'll talk about is a small interfering RNA that targets antithrombin, again cross-segment, available to treat patients prophylactically with hemophilia A and B with or without inhibitors. And then finally, SerpinPC, which is a serine protease inhibitor that targets activated protein C, again cross-segment and in early phase development. First, let's look at some of the long-term outcomes associated with emicizumab prophylaxis for hemophilia A with or without inhibitors, as this has the most longest duration of experience in the clinics to date. Emicizumab prophylactic therapy can be used whether or not patients have a history of an inhibitor, and it's really greatly revolutionized the care for patients. It's approved for use in infants all the way through adulthood. And the dosing regimens with emicizumab is once a week, once every 2 weeks, or even once every 4 weeks subcutaneously. The lower burden of administration has really transformed the lives of patients. What we see on this slide is a pooled analysis of the long-term results from the phase 3 studies of emicizumab prophylaxis in what's called the Haven studies 1 through 4. And this again is in persons with hemophilia A. And what we see on the left portion of the figure is the calculated mean annualized bleed rate in 24-week intervals after patients were initiated on emicizumab prophylaxis. And you can see over the course of the first year that the annualized bleed rate fell to very low levels, approaching 0. And if we look at on the right, the proportion of patients who experienced 0 treated bleeds during these 24-week intervals, we see that the proportion achieving 0 bleeds increases up above 80% and remains there, and these patients have continued to show good bleed protection over several years of follow-up. The Haven 7 trial was undertaken with collaboration from the hemophilia community to address the data gap of emicizumab in the youngest infant population. Currently, many infants with severe hemophilia A do not receive prophylaxis until at least 1 year of age. And this is due to the challenges of factor VIII administration in young patients, including venous access issues and the fact that many infants have required the use of central venous access devices that are also associated with additional risks. Now, emicizumab is approved in infants, and it enables initiation of prophylaxis from hemophilia A diagnosis via subcutaneous administration, and it may mitigate risks including spontaneous and traumatic bleeding, and most notably intracranial hemorrhages. And it may also have an impact on the development of factor VIII inhibitors, as these young infants can avoid exposures to factor VIII. So Haven 7 is a phase 3b multi-center open-label study of emicizumab in infants up to 12 months of age with severe hemophilia A without factor VIII inhibitors at enrollment. The treatment regimen was initiation on emicizumab at 3 milligrams per kilogram weekly for 4 weeks. This is the loading dose phase. And then they were on a maintenance phase of 3 milligrams per kilogram every 2 weeks for planned 52 weeks of follow-up. At week 53, the participants will be able to continue or switch to any of 3 different regimens that are approved, with an expectation to follow them over up to a 7-year long-term follow-up period. And the efficacy endpoints include the number of treated bleeds, all bleeds, treated spontaneous bleeds, and particularly treated joint bleeds. Now, questions from the community in this population included whether efficacious plasma levels of emicizumab could be achieved in the youngest infants. Secondly, what contribution does the physiologically reduced factor IX and factor X levels have on overall efficacy? And then finally, whether the monoclonal antibody would alter the factor IX and factor X levels, since that's the target for this antibody. Well, following the loading doses, the mean trough concentrations were 63.2 micrograms per ml, and the infants have maintained steady-state trough concentrations of approximately 60 to 65 micrograms per ml throughout the study period, which is actually above that reported in previous Haven studies. Notably, mean steady-state trough concentrations increased slightly with age until about 6 months, when they did reach 65 micrograms per ml. Notably, mean factor IX and factor X concentrations were not impacted by emicizumab treatment. The APTT was normalized by week 3 in most participants, although this was the first time point when samples were obtained for this determination due to the limitations in blood sampling volumes given to these infants. Emicizumab demonstrated consistent efficacy across the bleeding endpoints. A negative binomial regression model was used for this model-based annualized bleed rate calculation, which was 0.4 for treated bleeds and 1.9 for all bleeds. All treated bleeds were categorized as traumatic, thus an annualized bleed rate for treated spontaneous bleeds was not estimatable. For this interim analysis, the median age was 16 months. On the right side graphic, we show the proportion of participants with 0 bleeds by category. 77.8% had no treated bleeds, 42.6% had no all bleeds, and 100% had 0 treated spontaneous bleeds, and 98.1% had 0 treated muscle bleeds. So despite concerns about slightly lower factor IX and factor X levels in this patient in these youngest infants, this is still outstanding efficacy. And what's, I think, particularly impressive about the efficacy data so far, we have not observed any intracranial hemorrhages in the participants in the study thus far. Next, we'll shift to this next class of agents, which are the anti-TFPI agents. These are monoclonal antibodies, and they're currently under development for management of patients with hemophilia with and without inhibitors. Consistumab is one of the agents being explored, and this has been assessed in the Explorer 7 trial, which we'll talk about. And marstacimab has also been continuing in clinical development. It has already been published and shown to have meaningful reductions in the annualized bleed rate in a phase 1b/2 trial in participants with hemophilia A or B with or without inhibitors. It acts independently from factor VIII and factor IX, which is why it has this cross-segment efficacy. And by enhancing the initiation phase of coagulation through increased factor X activity, it can exert its action. And this allows ultimately sufficient thrombin generation in order to prevent bleeds. So consistumab is an anti-tissue factor pathway inhibitor. It's under development as a once-daily subcutaneous prophylactic treatment for patients with hemophilia with and without inhibitors. And results from the main part of the phase 3 EXPLORER-7 trial are presented by hemophilia subtype for patients with inhibitors. And what we see from this study to date is that once-daily subcutaneous consistumab prophylaxis was effective in reducing the annualized bleed rate compared to no prophylaxis in these patients with either hemophilia A with inhibitors or hemophilia B with inhibitors. And notably, the overall median annualized bleed rate was 0 across both subtypes. The next agent we're going to look at are antithrombin knockdown. So antithrombin is a natural anticoagulant. It's the major physiologic inhibitor of thrombin as well as factors 10A and 9A. Fitusiran is an investigational small interfering RNA therapeutic which targets antithrombin to restore sufficient thrombin generation and rebalance hemostasis in all people with hemophilia. And in phase 1 and phase 1/2 studies, subcutaneous prophylaxis with fitusiran resulted in sustained improvement in thrombin generation and a low annualized bleed rate. Now, the safety and efficacy of fitusiran has now been investigated in phase 3 studies as summarized here. The ATLAS-AB study was in adolescent males and adults with hemophilia A or B without inhibitors. It enrolled 120 subjects. Fitusiran was administered subcutaneous monthly, and it was compared to historical treatment with factor VIII or factor IX on demand with a 9-month follow-up period. The ATLAS inhibitor trial was also adolescents and adults with hemophilia A or B with inhibitors. It enrolled 60 subjects. Again, fitusiran was administered monthly. Bypassing agents were used on demand for comparison, and again, 9 months of follow-up. And then finally, the ATLAS prophylaxis study, adolescent and adult males with hemophilia A or B with or without inhibitors in this study. They enrolled 80 subjects. Fitusiran was again given subcutaneous monthly and compared to either factor or bypassing agent prophylaxis that the patients were on coming into the trial. And then after the switch to fitusiran, they were followed for 7 months on fitusiran. So the data from these studies was presented at the ISTH 2022 Congress. And in these two graphics, we see the mechanism of action of fitusiran. So on the left panel, across the top are antithrombin levels in individuals before they were administered fitusiran. And antithrombin levels are generally very stable in this patient population. However, after fitusiran dosing, within a couple of weeks, the antithrombin levels fall to very low levels, somewhere around 10 to 20%. And as long as patients remain on monthly dosing, they have sustained inhibition of antithrombin levels at that level. And then what you see on the right graphic is the impact on the peak thrombin generation. Across the bottom in the gray line are peak thrombin generation in the hemophilia patients before they were switched to fitusiran. And then in the blue line, we can see the significant rise in peak thrombin generation concomitant with the antithrombin knockdown. And what's notable about this graphic is that these levels are approaching the peak thrombin generation in unaffected individuals. As far as the efficacy in ATLAS-AB and ATLAS inhibitor, recall this is comparing fitusiran prophylaxis to on-demand therapy with factor concentrates or bypassing agents. And between these two studies, there was roughly 90% reduction in the annualized bleed rate, showing the efficacy of this agent as a prophylactic agent. But I think the big punchline comes from the ATLAS prophylaxis study. So what we see here are the median observed annualized annualized bleed rate in the individuals, whether they were on factor prophylaxis or bypassing agent prophylaxis. And the median observed annualized bleed rate was actually 4.4 bleeds per year. And we can see that it was only a minority of individuals that experienced 0 treated bleeds during the lead-in phase, just about 16.9%. But after the switch to fitusiran prophylaxis, the median ABR actually was reduced to 0. And now we see the proportion of individuals with 0 treated bleeds increase to 63.1%. Again, showing even superiority over prior prophylactic therapies. Accordingly, this has a significant impact on health-related quality of life parameters in people with hemophilia A or B with and without inhibitors. And the HemoQual instrument and TSQM-9 scores that were used to evaluate the health-related quality of life outcomes. This shows that fitusiran prophylaxis consistently improved quality of life endpoints in the adult and pediatric patients with hemophilia. And it illustrates the quality of life impact when you reduce bleeding in these individuals with fitusiran. So the final agent we're going to talk about is SerpinPC. This is a recombinant serine protease inhibitor which targets activated protein C, and is designed to increase the amount of thrombin sites of tissue damage by reducing the activity level of circulating activated APC, and thus prolong the activity of the prothrombinase complex of coagulation, which is the target for activated protein C. At the most recent ASH meeting in 2022, they presented evidence from what's called the AP0101 trial, and it showed that SerpinPC resulted in remarkable efficacy. In the left panel, you can see that the median ABR from these individuals on-demand therapy was quite high, anywhere from high 20s even into the mid-30s for annualized bleed rate receiving on-demand treatment. And after initiation on SerpinPC across different dosing ranges, we see a significant reduction in the all-bleed annualized bleed rate, and most notably the spontaneous joint bleed ABR. The all-bleed median ABR was 2.2. There were no observed treatment-related adverse events with this therapy, and no treatment-related elevations of D-dimer. So with that background, let's take some time to review some practical applications of how we make decisions about therapies for individual patients. This is a summary of factors that need to be considered in order to individualize hemophilia treatment. First of all, we pay attention to the patient's bleeding pattern. We get some predictions of this from their remaining endogenous levels. So severe hemophilia is less than 1%, moderate hemophilia is 1 to 5%. But even within those categorizations, it's the clinical bleeding pattern or the clinical bleeding phenotype of the patient that should drive treatment conditions. The condition of the patient's musculoskeletal system is important. Patients who have already inflamed joints, diseased joints, active arthropathy, active synovitis are likely to bleed more and may need more aggressive therapy. We pay attention to the level and timing of physical activity. This was particularly important with the peaks and troughs associated with factor protein replacement. But now with these non-factor therapies, we get a much more steady state hemostatic level of correction. And so this allows for a little bit more spontaneity on the timing of physical activity. Individual pharmacokinetics were a key part of evaluating, again, the factor VIII and factor IX prophylaxis. There's room for a little bit of pharmacokinetic modification with these non-factor therapies, and I'll show you an example of that in just a few minutes. Central venous access devices really aren't going to be a feature of future therapies, in my opinion, because now with this shift to low-intensity treatments and subcutaneous prophylaxis, patients just don't need to be relying on central venous access as much and can take advantage of these subcutaneous therapies. target joints are an active joint that's a source of repeated bleeding. I can say across what I've seen with the non-factor therapies, these have shown almost complete resolution of target joint bleeding once patients are initiated on these prophylactic therapies. We definitely pay attention to the likelihood of having a good adherence. It's hard to stay up with every other day infusion with factor VIII or even a couple of times a week with factor IX products. But once we shift to these lower intensity and lower frequency non-factor therapies, this has had an enhancement on overall adherence. And then, of course, we also pay attention to psychosocial factors to take into account what's the best treatment for that individual patient. This is a summary of my thoughts on the established as well as the emerging non-factor agents in hemophilia. Some of these emerging non-factor therapies may require less frequent administration than any of the available treatment options today. And in the most recent ongoing clinical trials, the non-factor therapies generally were administered subcutaneously. If we look at antithrombin lowering, that's once monthly to once even every other month. The anti-TFPI therapies range from once daily to once weekly. And so far, anti-APC is a once monthly treatment. These overall are less burdensome prophylaxis, and this may improve treatment adherence. It may lead to increased use of prophylaxis, maybe in patients who haven't been willing to embrace factor replacement prophylaxis, and I think we're seeing already evidence that's improving the quality of life of people with hemophilia. We also think about hemophilia over the lifespan. And so we've already introduced today that generally in infants, no prophylaxis is initiated with factor products until about a year of age. And so this is a gap risk for this age of patients with severe hemophilia, where they remain at risk for bleeds, even devastating hemorrhages like intracranial hemorrhage. And emicizumab, the emicizumab Haven 7 study is showing us that this really is a new option to close this gap and allow us to treat infants as close to birth as possible. Emicizumab in early childhood has advantages because of the subcutaneous delivery. We can use it regardless of their inhibitor status. I think it leads to better adherence. I like the stable, steady state that's achieved with these types of therapeutics, and that extends into the adolescent phase. Now, we still will see traumatic bleeds with the use of emicizumab prophylaxis, and so patients will still have to infuse factor from time to time, but I think this is allowing for more and more sports participation, not being so tied to the timing of the factor prophylaxis, allowing more spontaneity back into the lives of patients. I think some of the new agents we've talked about today, fitusiran, the anti-TFPI agents, are going to be nicely applicable to this age group and particularly active individuals. The adult treatment teams have also seen the benefit of emicizumab as it overcomes some of the challenges of venous access, particularly as patients age. But I think it's also allowed patients to undergo major procedures, particularly those who have inhibitors. So we see the benefit of emicizumab combined with the bypassing agents in both the pre and the post-operative setting in these individuals with inhibitors, where in some cases they may not have been even offered those procedures. Fitusiran, this is a potentially newer emerging non-factor therapy. I think it's going to have its immediate application probably in the adolescent and adult age group. One of the concerns with these agents that act with hemostatic rebalancing is the possibility that you could overshoot on that rebalancing. I showed you on the data that the peak thrombin generation starts to approach the lower bounds of the unaffected population. And on top of that, patients may still dose with factor products or bypassing agents for breakthrough bleeds on fitusiran. So risk mitigation has been built into the clinical trial program to use reduced doses of those agents to accommodate for the fact that these patients already have had partial rebalancing from fitusiran itself. This is also true with consistumab, and so these agents all have had risk mitigation be part of their clinical trial programs. This is an example of some follow-on data related to the mechanism of action of fitusiran. And the observation was that when antithrombin levels fell below 10%, this was putting patients at risk for potential vascular thrombotic events. And these were observed in the program. And so it was identified that antithrombin levels could be a potential modifiable target for risk mitigation. Perhaps having a lower antithrombin threshold of not less than 10%, but maybe not lower than 15%, could minimize the occurrence of patients transiently dropping into that less than 10% range. On the other hand, we don't want to lose the efficacy, and the data had suggested that antithrombin levels less than 25% may lead to the most desirable efficacy as measured by annualized bleed rate. And so maintaining an upper antithrombin threshold of about 35% was chosen to try to maintain that efficacy. So some simulations were done related to the pharmacokinetics and the pharmacodynamic modeling to identify a dose and regimen that could target antithrombin levels between 15 and 35%. And so a revised dosing schedule has been proposed now and implemented in the clinical development program. All subjects are now initiated at a dose of 50 milligrams every 2 months. And then if 2 or more steady-state antithrombin levels are above 35%, the dose regimen can be changed to 50 milligrams monthly. And again, if 2 or more levels are above that threshold, the subject would then be increased to 80 milligrams, which is similar to the phase 3 data I showed you earlier. Alternatively, if more than one antithrombin level is less than 15% on 50 milligrams every 2 months, the dose would then be decreased to 20 milligrams every 2 months. And then if after this dose regimen adjustment, more than one antithrombin level is less than 15%, the fitusiran would need to be discontinued. So dose escalation could be considered also if the subject has received at least 2 fitusiran doses and the investigator judged that suboptimal bleeding control was observed. So this dose optimization might seem complex, but actually it's expected that about 90% of persons with hemophilia would require either 0 or only 1 dose change following this algorithm. And about 80% of the participants will be treated with an every other month dose regimen. And it was estimated that the optimal dose would likely be reached within 3 to 6 months of initiation. So I like this approach. I think it's showing that we can adapt from the learnings from the clinical trial programs, we can individualize the therapy, and we can target patients properly and hopefully get the most optimal efficacy from these agents and avoid some of the potential complications. So that concludes our exploration of the noteworthy recent evidence with non-factor therapies in hemophilia. I hope you found this activity informative and useful for your practice. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/BEN860. This activity is supported by an educational grant from Sanofi.